Mr. Chairman, ladies and gentlemen, I have no financial interest in the material presented here. It's still not working, so. I've been assigned the topic of surgical management of iris and ciliary body tumors. Next slide, please. And I'd like to first point out that melanoma is the most important tumor of the iris that comes to surgical excision, and it's important for the clinician to differentiate melanoma from benign simulating lesions. Clinical experience is very important in order to avoid misdiagnosis and misdirected therapy. Next, please. If the lesion looks like a melanoma on the first visit, being elevated, pedunculated, or even overhanging the pupil, that's much more likely to be a melanoma, and you do not need to watch those. They need prompt treatment. On the other hand, if it's a flatter lesion that does not show such features, we did a study several years ago looking at a lot of patients who were sent in for iridocyclectomy or iridectomy, and we found that only 5% of suspicious lesions like that grow. So the majority of those non-suspicious lesions can be followed without immediate treatment. Next. Now, there are several techniques of surgical management of iris tumors, and I'm going to go through those listed here. Next. The purpose is to just quickly go over the indications and the techniques. I don't have time to discuss results, and this is covered in the recent literature and textbooks on the subject. Next. The first is fine needle aspiration biopsy. When one has a suspicious lesion where histopathology or cytopathology will alter your management, fine needle biopsy can be done. It's generally done with a 25 or 27 gauge needle through the clear cornea at the limbus, needle placed into the tumor, and cells obtained for cytopathologic analysis. Next. Most of the time we use it in difficult cases where the diagnosis is uncertain. Here's a pigmented lesion superiorly in the iris that was thought in this young person to be a melanoma, but needle biopsy showed epithelioid cells and an attempt at giant cell formation there, and this indeed was a juvenile xanthogranuloma, and the needle biopsy was very important in differentiating it from melanoma. Next. First, I'll talk about the surgical approach of iridectomy. I'm going to talk about techniques that we've used almost weekly in our practice for over 30 years. Next. The iridectomy is performed by doing an incision at the limbus of about 160 degrees using an 8-0 traction suture to elevate the cornea, and then go in and from either the pupillary side or the peripheral iris make a cut on one side. Next. On the opposite side, and then at the base. Next. And then the wound is generally closed with 9-0 nylon sutures. Next. If the patient has a small enough iridectomy, one can use a 10-0 proline suture to reconstruct the iris, and this pupilloplasty makes it look a little better. Next. Here's examples before and after of an iris melanoma that was resected, showing the resultant sector iridectomy. Next. And here's one that was smaller but documented growing, and the pupilloplasty was performed. The patient later became pseudophakic. Next. Next slide, please. Next is iridocyclectomy. When the tumor extends back into the trabecular meshwork or ciliary body, wider surgery is warranted. Next. The iridocyclectomy, I guess you just better move the slides. Next, please. First, one makes an outline of this in the dotted line here with transillumination, and a marking pencil is used to mark the appearance of that area where the tumor is. And then with a 4 to 5 millimeter margin, a scleral flap is designed. And next, that scleral flap is elevated by dissecting it forward and hinging at the limbus. The anterior chamber is then entered, and transillumination is reperformed at this point. Next. And then the tumor is cut out with about 3 to 4 millimeter margins, lifting it out with the inner scleral fibers. Next. And the flap is closed with 8-0 or 9-0 nylon sutures. Next. Here's the resultant sector iridectomy after an iridocyclectomy. Next. And in some of the ciliary body tumors, they only extend a short distance into the iris, and in these cases you can do a peripheral iridectomy. Note that the preoperative appearance of the tumor looks almost identical to the iridectomy area. Next. So what about enucleation? There are indeed indications where iris melanomas need enucleation. Here you see a 10-year-old girl who had this diffuse lesion. It was a little too big to do anything about. It was followed elsewhere, but she was sent in 3 years later with much more extensive pigmentation and uncontrollable secondary glaucoma. Next, this 10-year-old girl had enucleation and several years later died of metastatic disease. Now the next is something that you don't know much about perhaps, but that's plaque radiotherapy for iris melanomas that are unresectable. Here's an example of an elderly man who had diffuse melanoma, but the glaucoma was controllable. In a case like that, we use a custom-designed radioactive plaque. On the side toward the globe, you can see the arrangements of the seeds. Next. And that plaque is placed right over the cornea with the seeds directed toward the iris, and then that is covered with a conjunctiva and removed 4 days later. Next. Here's an example. Next, please. Here's an example of a man who had one eye. This was his only eye of an amelanotic melanoma. You can see inferiorly the ring involvement around the angle. And his other eye had been destroyed by trauma as a child. And here, 3 or 4 years later, you can see the cornea is still clear, the tumor has been excised, and it's been radiated, and he has had the cataract removed and doing well. Next. Now, I want to mention those extend from the ciliary body and iris a little more posteriorly into the choroid. We remove these by a technique called partial lamellar sclerouvectomy, and sometimes we can remove large mushroom-shaped tumors, as you see here, leaving the sensory retina intact. Next. Here's an example of one inferior equator. You can see the dome-shaped pigmented mass. Next. And there was a retinal detachment. The tumor was 10 by 9 by 5 millimeters thick, and this was over 20 years ago. Next. We did the resection. In the wide-angle photograph, you can see the resected area. The disc and fovea are intact. And look at the right side. You can see retinal vessels still passing over that scar, suggesting that indeed we've removed a big tumor, leaving the sensory retina intact. And this can be done in these cases, but the surgery is extremely difficult. Next. This is the same patient. We saw her recently, almost 25 years later, and she still has 20/20 vision in the affected eye. They don't all do that well, however. Next. So now that I've taught you everything there is to know about iris and ciliary body tumors, I'm going to have the audience have some fun and share with me an unknown case as to how you would manage this. It's an 11-year-old girl with a big mass coming out of the ciliary body and reaching the peripheral iris, as you can see. It's 10 millimeters thick, and this is the appearance with ultrasound. How should this be managed in an 11-year-old girl? Well, we advised enucleation, as did people at 3 other eye institutions on the East Coast. But very interestingly, this young girl didn't want her eye out, and the parents went along with her. She wanted to be a professional tennis player and have 2 eyes. So looking at this, we said, well, we can't radiate it because we'll destroy the eye. So with tongue-in-cheek and getting all kind of permits signed, we went ahead and resected this tumor with a partial lamellar sclerouvectomy. Next. And you can see as the tumor came out very nicely, and you can see with a nice scleral base this amelanotic dome-shaped mass. Next. And here's the pathology. Anybody want to venture what type of melanoma this is? Spindle cell melanoma? Or is it something else? It might be something else, right? Well, since you haven't got the diagnosis yet, I'm going to give you a hint. Here, next slide, please. What is this? This is the uterus. You didn't know you were going to hear uterine pathology in this corneal conference, did you? What tumor does the uterus spawn? Fibroid tumors or leiomyomas? Next. And indeed, this young girl had, next slide please, had a ciliary body leiomyoma. This surgery was done 20 years ago. This is the recent picture on your left. And she's done well now for 20 years and still has 20/20 vision. We saw her last month. Now, why were we able to do this? These interesting leiomyomas, next, have some interesting features. Next slide, please. They tend to occur in young adults, and they involve the iris and ciliary body, rarely in the choroid. They transmit light readily, unlike a melanoma, and they can be locally resected in some cases. We saw that case as the first, but subsequently reported 7 more cases, and now we've seen about 11. And we've learned that some of these cases don't grow in the uveal tract. They're between the sclera and the choroid and the ciliary body, so you can peel them out, and they come out very nicely. Next. And so in summary, we've talked in the last few minutes about some approaches to the surgical management of iris tumors. We've talked about needle biopsy, its indications and limitations, excisional biopsy, the unusual indications for enucleation, and brachytherapy or plaque radiotherapy. And we've shared with you an interesting case that teaches us something about iris and ciliary body tumors. Thank you.